Welcome to the Kanski lecture series, and it is going to be the retinal vascular diseases part 3. And in this part we are going to discuss about the treatment of the diabetic retinopathy. So first, there are general treatment of the patient. First, patient education is critical, including the need to comply with review and treatment schedules in order to optimize the visual outcome. In type 2 diabetes, this also involves counseling on weight reduction program and emphasizing the need to increase exercise. So the thing is, you have to counsel for reduction of weight and as well control of diabetes. Diabetic control should be optimized. Other risk factors, particularly systemic hypertension, especially type 2 diabetes and hyperlipidemia, should be controlled in conjunction with the patient diabetologist. So other things such as hypertension, hyperlipidemia should be controlled as well. Fenofibrate 200 mg daily has been shown to reduce the progression of diabetic retinopathy in type 2 diabetes, and prescription should be considered. The decision is independent of whether the patient already takes a statin. So fenofibrate is like 200 milligram, and it is basically being shown to reduce the diabetic retinopathy in the type 2 patient. Smoking should be discontinued, though this has not been definitely shown to affect retinopathy. Other modifiable factors such as anemia and renal failure should be addressed as necessary. Tip: the key to prevention of diabetic retinopathy is patient education and long-term control of blood sugar. So first is the treatment of diabetic macular edema. So if there is a macular edema in a patient of diabetes, so how we will treat this macular edema? Until recently, laser photocoagulation was the mainstay of treatment for DMO, reducing the risk of visual loss by 50% overall compared with observation. The availability of the intravitreal anti-VEGF agents and strong evidence to support their efficacy has dramatically altered the approach to management in recent years. So first, in previous years, the diabetic macular edema was treated with the laser photocoagulation, but now it is being replaced by intravitreal anti-VEGF. Many of the current guidelines for care have arisen from the conclusion of a large prospective randomized control trials undertaken by the Diabetic Retinopathy Clinical Research Network (DCR.net). It should be remembered that these studies provide average result in groups of patients and that individual response may vary considerably. So there are many trials that have been conducted for the treatment of diabetic retinopathy. DCR.net is one of them, but one should remember that every individual is different, and the treatment can vary from patient to patient, with some patients deriving little or no benefit from these intervention. Options should always be discussed fully with the patient. In particular, patient with a good vision 6 by 7.5 or better who otherwise meet the criteria for treatment might prefer to be monitored once the risk of various interventions are considered. So if the patient is having a diabetic macular edema and is being indicated for treatment, but his vision is good, like it is 6 by 0.57 or better, so one can discuss about the treatment, and also discuss that what are the risks for the treatment, and this should be discussed with the patient. The need for meticulous follow-up and the cost of proposed treatment may also be an issue for some patient and need to be considered when discussing therapy. Tip: anti-VEGF therapy has become the main therapeutic option in a treatment of diabetic macular edema. So it is an anti-VEGF agent. So 13.17 is showing anti-VEGF treatment for clinically significant macular edema. A is showing macular thickness map and OCT appearance prior to the treatment, showing diffuse thickening of the macular edema region 6 months after the treatment, showing reduction. So this is a map OCT which is showing the thickness of the edema, and you can see that there is a redness, which means that a macula is being thickened, and after the treatment it is has become blue to green color and the thickness has been reduced. So what are the treatment options? So intravitreal anti-VEGF agents are the treatment option. So DCR.net protocol I concludes that a intravitreal ranibizumab more effectively improves visual acuity than focal or grid laser treatment for central involved DMO. Laser treatment should be deferred for 6 months after the commencement of anti-VEGF therapy. Good outcomes can be expected for at least 5 years despite a sequential reduction in the number of an anti-VEGF agent. So there treatments have been defined by basically different trials. So drcr.net is basically one of the studies that has been conducted for the various treatment. So drcr.net have various protocol. So protocol I is have concluded that a patient who is on intravitreal ranibizumab is having a more improvement in visual acuity than focal or grid laser treatment for the centrally involved macular edema. And laser treatment in such patients should be deferred for at least 6 months after the commencement of anti-VEGF therapy, and even after 5 years, despite a success reduction in the anti-VEGF agents, good outcomes have been reported. Next is a drcr.net protocol T. Protocol T concludes that there are no difference in visual acuity at 5 years, irrespective of whether aflibercept, bevacizumab, or ranibizumab is used in patient with diabetic maculopathy, and a visual acuity of better than 6 by 15. However, aflibercept is more likely to improve visual acuity than bevacizumab in those with the visual vision of a 6 by 15 or worse. So next is a protocol T. So T is basically comparing the three intravitreal anti-VEGF. So there is an aflibercept, so there is an bevacizumab and ranibizumab. So if a vision is greater than 6 by 15, then there is no difference in any of the salt. But if the vision is worse than 6 by 15, the vision then aflibercept tend to do better than a bevacizumab. Laser photocoagulation, which is a modified ETDRS focal or grid laser treatment. So next is one can also do laser photocoagulation, although anti-VEGF therapy has replaced the laser treatment for most cases. So now we use mostly the anti-VEGF treatment for macular edema. This remains a well-proven therapeutic option. It should be considered in cases with off-center swelling that which when exudate threatens the fovea. So basically the laser photocoagulation can be considered if the center is not involved and there is an exudate that is threatening the fovea. So there are different type of laser photocoagulation. There can be focal, grid, and a modified grid. So focal dioid or argon burns are applied to the leaky microaneurysm 500 to 300 micrometer away from the foveola using a spot size of 50 to 100 micrometer, duration of 0.5 to 0.1 seconds with sufficient power to obtain a grayish reaction beneath the microaneurysm. So one can focal laser is that if there is some aneurysm in the macula which is about 500 to 3000 micrometer away from foveola, so you can laser photocoagulate that microaneurysm. And what are the settings that you use? You can use about the spot size of 50 to 100 micrometer with the duration of 0.05 to 0.1 second. So next is there is a grid laser as well. So grid burns are applied to macular area of diffuse retinal thickening, treating no closer than 500 micrometer from the foveola and 500 micrometer from the optic disc using a spot size of 500 to 50 to 100 micrometer and a duration of a 0.05 and 0.1 second with a power adjustive to give a mild reaction. A modified grid include a focal treatment to foci of leakage, usually microaneurysm. So grid laser means that if the area is diffusely thickened, so you can do the laser photocoagulation, but you make sure that the laser is almost 500 micrometer away from the foveola, and it is also away from the optic disc 500 micrometer away from the optic disc as well. And modified grid laser mean that you make a grid laser as well as you put the focal laser on the microaneurysm as well. Then there is a subthreshold micropulse diode laser. The modality use a very short microsecond laser pulse duration combined with a relatively longer interval, for example 5% duty cycle, allowing energy dissipation. This minimizing collateral damage to the retina and choroid while stimulating the retinal pigment epithelium. Subfoveal therapy is possible. The result from clinical appearance with subthreshold laser therapy are favorable, but there are no clinical trials showing superiority to conventional laser or anti-VEGF treatment. So basically, subthreshold micropulse diode laser is you just put on the laser of a very short duration, and after that there is a long interval in which there is a energy dissipation. And what is it is doing, basically it is minimizing the collateral damage to the retina and choroid, and while stimulating the retinal pigment epithelium. Uh, and the results have been shown that a subthreshold laser therapy are favorable, but there are no clinical trials showing superiority to conventional laser or anti-VEGF treatment. Tip: improvement in a best corrected visual acuity after 3 injection of anti-VEGF medication is a strong predictor of the long-term response in a patient with a diabetic macular edema. So if you basically inject the 3 injection of anti-VEGF of, so it can conclude that what is going, if the visual acuity improves, it will conclude that how the patient is going to respond in a long term. So this is a laser for a clinically significant macular edema. A is showing prior to modified grid laser. C is showing appearance after 2 months, and A immediately post grid laser, and C is showing appearance of after 2 months. So you can see that there is a macular edema, there is a hard exudate. In this picture, the grid laser has been applied along it, and on third you can see that the macular edema has been improved. So next is the intravitreal triamcinolone. In a pseudophakic eye, intravitreal triamcinolone intrasteroid injection followed by a prompt laser is comparable to ranibizumab with regard to visual improvement and reduced retinal thickening. So there is another treatment you can also give intravitreal triamcinolone, but we give it in pseudophakic patient. Why? Because in a phakic patient it can induce glaucoma, as well as it can induce the cataract as well. So these are the potential complications. That is why we avoid it in the phakic eye. And if you just in a pseudophakic eye, if you give intravitreal triamcinolone, and that is followed by the prompt laser, it is results are compared to ranibizumab. This is a good therapeutic option in pregnancy or when there is a contraindication to anti-VEGF treatment, for example recent myocardial infarction. However, there is a significant risk of inducing an elevation of intraocular pressure. This must be monitored regularly. In a phakic eye, there is an increased risk of cataract. Sustained release intravitreal steroid implants have demonstrating previous promising results. So they are implants that you can inject intravitreally, which release the steroids in some amount for longer duration of time. So this is a subthreshold micropulse diode laser for a clinically significant macular edema. A is showing macular thickness map and OCT appearance prior to the showing treatment, showing a thickening of a macular region below the fovea, and B is showing the 3 months after the treatment, showing no edema. So this is how the subthreshold micropulse diode laser has responded before the treatment, and it is showing after the treatment. So next is the pars plana vitrectomy. So pars plana vitrectomy may be indicated when a macular edema is associated with tangential traction from thickened or taut posterior hyaloid. So if there is a very taut posterior hyaloid membrane that is causing traction on the macula and causing the macular edema, you can always go for PPV. It has also been suggested that some eyes without a taut posterior hyaloid may also benefit from vitrectomy. Clinically, a taut thickened posterior hyaloid is characterized by an increased glistening of the premacular interface. FA typically show diffuse leakage and prominent CMO, but OCT is usually the definitive assessment. So usually the OCT is basically the definitive for the PPV. There are several other indications for PPV in the management of a diabetic eye disease. Specific recommendations. So now we have discussed all type of treatment options for a case of a diabetic macular edema. So now we will see that in what case how we will treat the patient and what medication or what treatment we can use. So if there is a clinical significant macular edema which is not involving the center of the macula, particularly where exudates threaten the fovea, may be treated with laser treatment in the form of a continuous wave focal or modified grid laser photocoagulation. If available, subthreshold macular laser treatment, intravitreal anti-VEGF therapy, or intravitreal steroid implant may be reasonable alternative for this indication. So if there is a CSMO which is not threatening the which is not involving the center of the fovea, and what the exudate is threatening the macula, you can always do the grid laser photocoagulation. But if you have like other treatment option available like intravitreal steroid implant, intravitreal anti-VEGF, then it is a better alternative for the laser. And if there is a CSMO involving the center of the macula but with a visual acuity of better than 6.15, it can be treated with aflibercept, bevacizumab, or ranibizumab. So this is discussing the drcr.net protocol T. So if the visual acuity is greater than 6 by 15 but the macula is involving center involving macular edema, you can use any of the salt, aflibercept, bevacizumab, and ranibizumab. However, bevacizumab reduces OCT swelling less effectively and is more likely to result in a persistent DMO than other agent. Alternatively, subthreshold laser can be considered. If a laser is to be used, it is prudent to treat no closer than 500 micrometer from the perceived center of the macula. But if you want to use, you can also use laser, but the laser should be away from the center of the fovea, 500 micrometer away. Then, as if the CMSO is involving the center of the macula but with the visual acuity of 6 by 15 onwards, and significant foveolar thickening should be considered for aflibercept treatment with initial induction, usually using monthly injection for 3 to 6 months, and as needed approach can subsequently be adopted. So, if you know, it is also discussing the drcr.net protocol T, in which there is basically if the vision is less than 6 by 15 onwards, you can the aflibercept tends to do better. And first you give the 3 to 6 continuous injection for 3 to 6 months, and then you give as needed approach for the injection. Focal or grid laser should be deferred for 6 months, and intravitreal dexamethasone, and this is us discussing the protocol I, that if you start intravitreal anti-VEGF, you defer the laser for 6 months. An intravitreal dexamethasone implant is an alternative treatment that may be considered in patients with absolute or relative contraindication to anti-VEGF agent injection. So you can also give, if there is a contraindication to anti-VEGF, you can also give intravitreal dexamethasone implant as well. In a patient who have transient but significant reduction in macular edema, switching to fluocinolone acetoid implant is a reasonable alternative as it is longer acting and therefore will reduce the need for repeated dexamethasone injection. In eyes with PDR and coexisting DMO, ranibizumab or aflibercept treatment alone should be considered rather than pan-retinal photocoagulation and ranibizumab or PRP and aflibercept. So if the patient is having a diabetic macular edema plus PDR, then you should alone consider the ranibizumab or aflibercept rather than you give do PRP as well as you do give the anti-VEGF agent. In eyes with persistent diabetic macular edema for after 6 months of anti-VEGF monotherapy, consider adding laser or switching to an intravitreal dexamethasone implant if there are no contraindication. So if the patient is on the intravitreal anti-VEGF agent but the diabetic macular is persistent after 6 months, you can always switch to laser or you can add the dexamethasone implant. Eyes with markedly reduced vision due to diabetic macular edema often have an associated macular ischemia and therefore poor prognosis. Optimal management for this group of patients have not been determined. Depending on the circumstances, including the severity of macular edema and the level of ischemia, any of the intervention discussed above may be considered. So, if there is a macular ischemia, you cannot do much about it because there is a macular ischemia and there is a poor prognosis for that. In her resistant cases, sparse planar vitrectomy may be considered, particularly if a vitreomacular traction or a marked epiretinal membrane is present. Tip is pan-retinal photocoagulation continues to be the mainstay of proliferative diabetic retinopathy treatment in most healthcare systems. So this is a retinal appearance several weeks after laser. B is showing composite image of pattern scan multiple spot array treatment. C is showing before treatment of severe proliferative diabetic retinopathy, and D is showing 3 months later new vessels have regressed. There is a residual fibrosis on the disc. So you can see that this is after the PRP has been done, and this is a newly formed PRP. This is, you can see that there is a new vessels and before treatment, and this is an after treatment, there are regression of the new vessels as well. So next is the treatment of the basically proliferative retinopathy. So there is a laser treatment for a proliferative retinopathy. So there can be the scatter laser treatment, there can be anti-VEGF, and there can be the targeted retinal photocoagulation. So laser treatment for proliferative retinopathy, scatter laser treatment, pan-retinal photocoagulation continues to be the mainstay of the PDR treatment in the most healthcare system. So when there are new vessel formation, PRP, pan-retinal photocoagulation, is basically the mainstay of treatment in most of the cases. And the diabetic retinopathy study, DRS study, establishes the characteristic of a high-risk proliferative disease and demonstrates the benefit of PRP. For instance, severe NBD without hemorrhages carries a 26% risk of a visual loss at 2 years, that is reduced to 9% with PRP. However, recent research protocol S from drcr.net shows that a course of injection of intravitreal ranibizumab is as effective as photocoagulation in a patient at a high risk of PDR at 5 years. So first is basically we are going to discuss different studies. So there is a DRS study which basically shows that if we in a severe and in a case of a high risk proliferative disease, there is a benefit of a PRP. For example, if there are severe NVDs and without hemorrhage, the risk of visual loss at 2 year, which is about 26%, can be reduced by 9% with PRP. And protocol S is basically drcr.net protocol, which is showing that intravitreal ranibizumab is as effective as a photocoagulation in a high risk PDR at 5 years. And there is a clarity study. In addition, the clarity study provide 1 year data that shows that intravitreal anti-aflibercept injection are as effective as PRP in the treatment of PDR. So clarity discusses about the intravitreal aflibercept, which is having a same effect as PRP, and the drcr.net was discussing about the ranibizumab, which has having the same effect as a PRP. So that's it for the retinal vascular disease part 3. See you in the next lecture.